All right. Good afternoon, everyone. Thank you all very much for coming. This is the short access to a successful prehospital ultrasound program. Some introductions. My name is Ryan Tucker. I'm a emergency ultrasound fellow at Denver Health. I have a fantastic panel with me today. They're going to introduce themselves here.
My name is Torben Becker. I'm a faculty member at the University of Florida, involved with the EMS programs, ultrasound programs, and critical care programs there.
My name is Mark Lowell. I'm a faculty member at University of Michigan and medical director for Survival Flight, the critical care transport program that incorporated ultrasound with the help of these gentlemen.
My name is Ross Kessler. I'm a faculty member at the University of Washington in Seattle, most recently as the co-director at the University of Michigan for clinical ultrasound, and helped to establish the flight ultrasound program there.
And my name is Michael Covert, also from University of Michigan, helping out with the Survival Flight ultrasound curriculum there.
All right, so our learning objectives for today, we're going to summarize the current data that supports prehospital POCUS while highlighting some of the strengths and limitations of that data. I have a summary sheet just up front here in the front chair that has the what I've picked out as some of the important pieces of literature prehospital POCUS, so take a look at that. We're going to identify some of the important applications of prehospital POCUS. We're going to define the benefits of prehospital POCUS program and the advantages of that to your institution. And finally, we're going to construct a framework for initiating prehospital POCUS. And so what I'm going to ask is that if you have questions, you can step up to the mic and ask our great panel here. So feel free. I want this to be an interactive session for you all. And so I'm going to kick it off with a question for Torben. So I think we all have really good anecdotes of cases that have gone really well, and EMS providers using prehospital POCUS to make important diagnoses. I think the question next is how do we move that to the next step, and how do we implement programs? So I was wondering if you could talk a little bit about some of the challenges in doing that.
Yeah, I think the biggest challenge is very easy. It's called money. Because if you want to implement an ultrasound program in your EMS system, you're going to have a high upfront capital investment for this. You're going to have to not only buy ultrasound devices for your service, you also have to train everybody, right? So that's a lot of money, particularly if you're an EMS medical director for a fire rescue service, such as where I work. Every training needs to be paid for. People are not even allowed to be there without getting paid, right? So even if you have people who are really enthusiastic, they can't just come in and learn and not get paid. So that's a problem. In addition to making a decision, which units are going to get these ultrasound devices? Am I gonna buy an ultrasound device for every single unit in service? That's going to be really, really expensive. If I'm not doing that, I have to make a very educated decision about what units am I going to place it on. Is it only going to be the critical care transport services? Is there some type of supervisory role, for example, an EMS district chief who will carry those devices and bring them to the scene? Does that make sense? Can they be on scene within reasonable time for a patient that may benefit from an ultrasound at the scene, and so on. And then the other big question, once you figured out is this even feasible from a financial perspective, is how would you define indications for use of pre-hospital ultrasound? What is the evidence base to say we should be doing pre-hospital FAST, pre-hospital lung ultrasound? And if you start looking at that, and some of that is on those handouts that you're looking at right now, you realize that the evidence base is pretty thin, and even worse, a lot of it is not really in support of ultrasound in the field, particularly for those studies who look at it from a feasibility standpoint, and not just from kind of a case series. We got 3 guys to carry an ultrasound, they were really into it, and they scanned a bunch of people and they thought it helped, but actually looking at, okay, did it work? What were the challenges they encountered, and did it actually change patient outcomes?
Thanks, Torben. Does anybody have any questions about that? Great. And I think Torben touched on something in his answer there that I wanted to ask Ross about is, do you think pre-hospital ultrasound, do you think this should be a protocol driven enterprise where a lot of EMS systems have protocols for different complaints and different conditions. Do you think ultrasound should be integrated into those protocols, or do you think that the use of prehospital POCUS should be left up to the discretion of the provider?
Yeah, so I think in terms of protocols, EMS is very protocol driven. Based on our experience at Michigan, I think you definitely need to give some flexibility for the providers, or whether or not they actually want to do the ultrasound, because there's certain limitations, especially if you're talking about ground EMS in terms of time. Right, not everyone is actually going to need an ultrasound. And with us in the emergency department, I'm an ultrasound faculty member, and I don't perform an ultrasound on all my patients as well. So I think if you make it mandatory for each transport for someone who's shortness of breath to do an ultrasound, I don't think you're going to get a lot of buy-in for that. So I do think you need to provide some flexibility in terms of the protocols.
And I had this one for Dr. Covert. Which applications of POCUS do you think would be most useful to the pre-hospital providers, and how should we invest our time in terms of training these providers in terms of which applications to apply?
So short answer there, I think, is it depends on your particular situation, where your providers are going to be practicing, whether you are in an urban setting in which your transport times are 4 or 5 minutes on average, compared to a scenario in which your transport times are 30 minutes, 45 minutes in the Upper Peninsula of Michigan, for example. And it will vary too, depending on the skill level and training background of your provider. So if you have physicians in your rig or in your helicopter that can perform pretty advanced ultrasound, that's a different situation compared to an EMS provider, an EMT basic, something that has no previous ultrasound knowledge and minimal training, like Torben was talking about. If you have somebody with absolutely nothing prior to your education, you're going to be able to do limited scans and probably have to protocolize a whole lot more of that. And then the second thing is, I think you have to invest your time and resources wisely into things that may actually benefit the patient. And so you're not going to want to spend time on like renal ultrasound, for example, because it's not going to change anything in the ambulance. So ideally, I think you want to focus on things that can help the EMS provider make a decision about how can I help this person and how can I avoid harming them. So are fluids good or bad? If they have blood available, should I give blood, or should I focus more on vasopressors? If they have the protocol leeway to give diuretics, some of those things, some of those decisions are important, where basic focused cardiac, lung, IVC, and so forth may be really helpful.
Cool, gotcha.
And I think just to piggyback on that real quick, a really important aspect of that is that if you want to implement some pre-hospital ultrasound, you need to make sure that, or you need to consider that this can be a system-wide implications, and that an application may be helpful and useful in one system but not in the other. A good example, for example, is a lot of ultrasound companies are interested in doing pre-hospital studies now, and one that we've actually got approached a couple of times about now in the past year is doing pre-hospital fast studies, right? I think there are a lot of issues with doing pre-hospital fast, but one of the biggest questions is, if you want to implement that, is that something that's actually going to change the course of your trauma patients in your local environment? Are your surgeons going to be willing to take the patient directly to the OR because of a pre-hospital fast exam, right? That's a pretty big ask, right? If they say, I don't care about the pre-hospital ultrasound, then there is no purpose in doing it, right? Because it's likely deviating important attention and resources from that patient in that critical situation, and unless you have a really long transport time and it helps with the triage decision about going to the trauma center or not, which by itself would be a very slippery slope, then you're really not going to have a lot of impact with investing money and time and resources into a pre-hospital FAST program. If you have surgeons who are really excited about this, who want to work with you, say, okay, we'll take this patient to the OR straight from the ambulance bay, or at the very least, we integrate that into our trauma alert criteria, and we'll use that to upgrade to a level 1 alert, or these kind of things, then it may have impact and may actually change patient outcomes. But if not, then you really have to ask yourself, even if you're like really into ultrasound and biased in wanting to do ultrasound, which a lot of us in the room are probably are, you have to ask, are you going to do more harm with that? Because now your crews are trying to do ultrasound fast exams, which is going to take 5 minutes for them to do in the field, versus focusing on airway, focusing on preventing further extremity MSK injuries and so on, and potentially delaying transport to definitive care for this condition where we know that fast, rapid transport can, in certain cases, actually be life-saving. One of the very few indications in pre-hospital care where speed actually matters.
Yeah, just to piggyback on that, I think you need to think about what system you're going to be rolling this out to. So if you're thinking about flight systems where you have 2 to 4 hours of transport time, then you're going to want to have them someone to do a more comprehensive exam where they're looking for volume status and cardiac function, which we found that actually did change management in up to a third of our patients when you're looking at air transport EMS systems. But if you're looking at ground transport systems, like in Seattle where the transport time is only 10 minutes, then you don't want to necessarily waste your time doing a whole comprehensive exam. You may just want to pick one thing like lung ultrasound, where it's going to basically help you to determine whether or not I should treat this patient one way or the other. So I think you really have to think about what system you're looking at.
Yeah, to sort of piggyback upon that, just to make emphasis on our project and what we did, was that we have a group of about 20 or 21 flight nurses that are full-time flight nurses. And they're mine or ours, so we get to train them however we want, whenever we want. And that's how we were able to get them pretty much the same training. Another thing about our program is we don't do much pre-hospital or scene work. Most of what we do, between 90 and 95%, is inter-hospital. So our applications that we've been using have not really been focusing on fast, but it's been focusing on causes of shock, volume assessment, et cetera. And from that standpoint, we've been fairly successful. Of course, like any other program, we'll have the people that are really into it, the people that want to ultrasound everything and every time they can, and others that have been a little bit more difficult to get to adopt it. And that's why it's within our clinical guidelines, we don't call them protocols, for them to use it when they feel comfortable and when we think it can help. And if there's a case where I thought they could have used it and they didn't use it, then they're in my office the next day to explain why they didn't. We believe in it. We think it's an important part of an addition to our flight nurse curriculum, and we think it's been helpful.
Torben, as someone who's used ultrasound in the field like you, I think you have a good perspective on this. And could you talk a little bit about some of the unique challenges that come with using ultrasound in the field?
Yeah, I think there are a number of challenges, unfortunately, and I am definitely hugely biased. I have 2 handheld ultrasound devices that I personally own. I respond into the field several times a week with our response vehicle, and I ultrasound everybody in the field, right? So unfortunately, despite all that, despite being biased to that degree, I have quite significant concerns about the widespread, unfiltered adoption of pre-hospital ultrasound. We did, a couple years ago in Pittsburgh, we did a study looking at pre-hospital ultrasound, and it was a feasibility study where we actually defined feasibility a priori. We kind of looked back at the origins of 12-lead EKGs in the field. And we came up with a formal protocol, had them go through that, we trained them, all that. There was quite a bit of an upfront investment in training and so on. And we essentially, unfortunately, had to come to the conclusion that for lung ultrasound, pre-hospital ultrasound was not feasible. It did not meet our pre-established feasibility criteria. A big issue with that was that the devices are not really made for the pre-hospital environment, particularly the handheld devices, which from a cost perspective and portability perspective kind of lend themselves to that environment. Big issues were battery life, for example. A lot of times the scan couldn't be performed because all the batteries had died. Another one was the kind of lack of ruggability, so to speak, of the device and damage to the device in that environment. Or one that we didn't even think about was, for example, the screen of the device. We typically do the ultrasound in the emergency department where there is artificial lighting, and we turn off the lights if we want to get a real good look, right? In the pre-hospital setting, if you're doing it in the ditch somewhere by the road on a sunny day, you don't see anything on the screen. There's so much glare that you just couldn't see anything. One thing that this led to is that our medics started to overgain all the images because they wanted to see something on the screen. And so when we were QAing those images, everything was just white. And that didn't really lead to quality images. So I think there is a technical component to this as well. Do I ultimately hope for pre-hospital ultrasound to be successful? I surely do, but I think that we have a lot of challenges ahead of us.
Gotcha. So maybe too sunny in Florida to do pre-hospital ultrasound. It's not an issue in Michigan. Trust me. Since all of you have been involved in kind of developing a program, building it from scratch, I wonder if you could talk about some of the hard lessons you've learned or things you would have done, things you do differently if you were starting a program new.
I do think that you need to treat it just like you would treat a resident training program or fellowship program, and not kind of lower the standard in terms of the training. And so I think that if you're going to do it, then you need to do the same quality assurance that you would do. So at Michigan, we were pretty adamant about making sure that the flight nurses uploaded the images to our quality assurance kind of cloud-based system to be able to look at it, and that was kind of hit or miss. In terms of whether or not they would do that, depending on the tech, which is the obstacles that Torben has kind of discussed. But I do think you kind of have to have the same kind of level of expectation where, okay, if we're going to do this, let's talk about exactly what's our training program going to look like, what's our quality assurance program going to look like. They should document in the chart, if possible, and treat it similarly, as opposed to kind of just being like, oh, well, let's do this and figure out as we go. I do think you need to have think about it very kind of formally, because if there is a bad outcome, then you want to make sure that you can do the same type of quality assurance that you would otherwise.
All right. So we got a few minutes left here. I was wondering if you guys wanted to share a story of a success that pre-hospital ultrasound really benefited a patient.
I think, like Mark Lowe was saying, we do at Michigan a lot of inter-hospital transfers, and so that's where a lot of our ultrasounds are performed instead of the true pre-hospital setting, and far less trauma and scene calls. But as any of you who work at tertiary care hospitals or even hospitals you get any sort of transfers from another place are aware, you get a story from another hospital that has worked up a patient to some degree, and oftentimes they're right and sometimes they're not. And I think those are the ones where it has really helped quite a bit, where one in particular fairly recently was a case of what was billed as septic shock and hypoxic respiratory failure, and the survival flight nurses did a focused cardiac lung IVC type of ultrasound, and in fact it was cardiac tamponade. And in this case, they didn't have a fever. They didn't have a leukocytosis. They didn't have any clear lung findings on X-ray where they said, the other hospital had said, well, this is pneumonia and septic shock and hypoxic respiratory failure. And so in that case, if they had continued with the treatment plan that had been started, which is antibiotics, lots of fluids, BiPAP with pretty high PEEP, that person could have been harmed even more than they had already, frankly, somewhat iatrogenically, and they could have coded and died. So that removal of BiPAP with really high PEEP, diagnosing the tamponade, shifting the diagnosis and management plan was, I think, pretty life-saving for that particular patient.
Some examples that I recall is if you have the undifferentiated patient, let's say the nursing home patient where EMS gets called and nobody is there who knows anything about the patient, and the patient themselves is demented or has an altered mental status, can't give you any history, and you have no idea what's going on with them. Doing a quick blood blue and rush protocol, I guess we could call it blush protocol, on them, can be sometimes really helpful if they have abnormal vital signs. This is one of the cases where I found lung ultrasound to be helpful to get an idea of what's going on with these patients, why are they hypoxic. So I think that's a good example. Another example also, which is truly just an anecdote, is that just the other day we went out to a patient who calls for chest pain all the time. She's 35 years old. Nobody really thinks that there is, that she is like a high-risk cardiac patient, right? This is the 5th time a week that a patient, that the ambulance is being called, and they're otherwise young, don't have a lot of risk factors. But she actually had a big pericardial effusion. That certainly steered her treatment course towards, oh, you definitely need to go to the hospital for some additional testing, as opposed to essentially obtaining a refusal on scene, so to speak.
My second favorite anecdote after the one Dr. Covert had mentioned is contrary to what Dr. Tucker had mentioned about a surgeon not believing pre-hospital ultrasound. Our nurses brought somebody in who said the FAST was positive, and the surgeon said it was negative, and it turns out the nurses were right, and the patient ended up having to go to the OR. So there's always the opposite side of the coin as well. Yes.
So I guess the lesson of the story there is you're going to find a lot of tamponade if you start scanning a lot of people. I think personally, some of my favorite anecdotes about this, I was a resident at Michigan, and we're involved in some of the training session for the nurses, and I had never taught anyone more enthusiastic than the flight nurses. They were very excited about it. They were very fun to work with, very fun to teach. We would do some scanning on shift with them, and they were great, fantastic students. So, all right. Does anyone have any questions? We'll stick around here so you can come up and ask us some questions too. Dr. Fung, yes, question.
What do you guys think about a model where you, the pre-hospital provider just requires the images and physicians will interpret the images?
So I think that that's difficult to implement in reality because you're going to need a physician to be on call to interpret those images, and it also involves making sure that those images can get up to a cloud in a timely fashion. So I think there's a lot of kind of rate limiting steps to be able to implement that. So I would say if you're going to think about that, you have to make sure that all your tech works. You make sure you have faculty buy-in to make sure that you're going to have someone who's going to be, hey, I'll look at those images at 2 o'clock in the morning on your pre-hospital ultrasound, which I think may be difficult to do. So I would kind of recommend, having the paramedic or the flight nurse be the one to interpret the images, as opposed to having like medic control or physician interpret the images. But I believe, Torben, you had, in the Pittsburgh study, you did something different, right?
Yeah, in our study, we actually, because we came with the intention of kind of modeling the early beginnings of pre-hospital 12-lead acquisition, which initially also involved remote transfer and interpretation. We did that model where our medics acquired the images. We taught them some basic interpretation skills, but we also, because we didn't really change care in that feasibility study, we also had them send it to a central review, so to speak. That was, it's a large urban EMS system that has a 24/7 control center with a physician just dedicated to EMS medical control and so on. And so it was feasible in that setting, but that is very unique and rarely found across the nation. And we did have a lot of technical issues with that as well. So just as Ross said, uploading it into the cloud, lack of internet connection, and all these things that really makes it difficult. And I would advocate for really focusing on training your pre-hospital crews to be able to do these types of exams and interpret them, and not just obtain the images and waiting for somebody else to look at them. I still think there may be some merit in transferring them to have some ability for like kind of a real-time QA, for example, particularly if you're talking about a patient going on longer transfer and so on. But I think they should have the ability to interpret on scene and maybe have this kind of backup where they can speak with the medical control physicians if they're not entirely clear how to interpret an echo, for example.
All right, so I think we'll end it there. Thank you very much for coming. Any questions you may have, don't hesitate to email me or send me a message on Twitter. Thank you very much.